Hello, welcome to another episode of Arthritis and You, a Joint Journey. Today, we've got something special lined up, so buckle up because it's time for the deep dive. Let's give a warm welcome to our hosts, Arthur and Sarah.
In the world of cancer treatment, we've seen some truly incredible advancements, haven't we?
Absolutely. Game-changing, really.
Think about immune checkpoint inhibitors, ICIs. These are amazing therapies that basically, release the brakes on your body's own immune system.
Letting it go after the cancer cells.
Exactly. They've just fundamentally reshaped how we approach so many diagnoses, offering real hope where sometimes there wasn't much before.
For sure.
But here's the really tough question, the dilemma. What happens when a patient who already has an autoimmune disease?
Right, where their immune system is sort of already overactive or misdirected.
Yes. What happens when that patient needs the same powerful treatments that ramp up the immune system even more?
That's a huge challenge.
That's the complex issue we're diving into today. Our mission here is to really unpack the critical things to consider when ICIs are used in patients with these pre-existing autoimmune conditions.
Yeah, looking at how well they work, the safety.
Exactly. Efficacy, safety, and also the very tricky role of other medications, like immunosuppressants. We're pulling from the detailed information we have.
And it's definitely not straightforward.
No, it really demands careful, case-by-case decisions. Usually involves oncologists, rheumatologists, other specialists, all working together.
Yeah.
It's fascinatingly complex.
It really is.
Okay, so we've got this amazing tool, ICIs. But like we said, giving it to someone whose immune system is already kind of prone to attacking itself, well, the first big question has to be, does it even work?
Right. Are these ICIs actually effective against the cancer in someone with an underlying autoimmune condition?
Yeah, it feels like you might just be pouring fuel on a fire, doesn't it? Intuitively.
That's the initial worry, definitely. But what's quite surprising or maybe encouraging from the data we have, and this is mostly from looking back at patient records, retrospective studies, is that the answer seems to be yes, they do work. Patients with pre-existing autoimmune diseases seem to get similar benefits, similar efficacy compared to patients without those conditions.
Really? Similar efficacy?
Yeah. It means that even with that baseline immune issue, the ICIs can still often trigger an effective anti-cancer response. The objective response rates, that means, tumors shrinking or disappearing, they tend to fall somewhere between 20 and 40% in these studies.
Okay, 20, 40%.
Which indicates that for a good number of these patients, the treatment is definitely having a meaningful impact on the cancer itself.
Wow. That's actually quite positive, isn't it? Considering the potential complexities.
It's very positive, especially for patients who historically might not have even been considered for these drugs.
So on the efficacy front, maybe a tentative green light. It seems like they can work.
It does seem that way, yes.
But, in medicine, it's never quite that simple, is it? There's always another side to the coin.
Always. If it works, the next logical question is, at what cost? What are the risks?
Exactly. And this is where it gets really, really interesting or maybe just more complicated. Historically, you mentioned these patients were often kept out of the big clinical trials for ICIs.
That's right. They were typically exclusion criteria.
So why? Why were they excluded? What were the specific safety concerns that led to that? It seems like a pretty cautious stance.
It was caution, absolutely. They were excluded precisely because of the worry about increased toxicity, increased side effects. So while the tumor response might look similar, as we just discussed, the rate of adverse event side effects in patients with pre-existing autoimmune diseases can be, significantly higher.
Higher than in patients without those conditions?
Yes, potentially much higher. And this is where the numbers really highlight the challenge.
Okay, let's hear them.
So picture this. Roughly 2/3 of patients who have an underlying autoimmune condition will likely experience an immune-related adverse event, an IRE, when they're treated with ICIs.
2/3, that's a lot.
It's a very high proportion. These are those side effects where the boosted immune system starts attacking healthy tissues, not just the cancer.
Right. And what kind of side effects are we talking about?
Well, digging into that 2/3 number, about half of those patients will experience a flare-up of their existing autoimmune disease.
So their lupus or rheumatoid arthritis, whatever it is, gets worse.
Exactly. It becomes more active, potentially causing significant problems, pain, complications.
Okay. That's one major issue.
And it doesn't stop there. Roughly 1/3 of the total group, So about a third of all patients with pre-existing autoimmunity getting ICIs will develop what we call a de novo IRAE.
De novo, meaning new.
Correct. A completely new immune-related side effect, something they didn't have before, wasn't part of their original autoimmune condition.
Wow, so not just making the old problem worse, but creating a brand new one.
Precisely. It could be thyroid issues, colitis, pneumonitis, skin problems, a whole range of things caused by this newly activated immune response attacking healthy organs.
That really paints a picture of a delicate tightrope walk for doctors and patients.
It absolutely is. Balancing benefit and risk is critical here.
So, with such a high rate of these adverse events, two-thirds experiencing something, what does that mean for actually staying on the treatment?
That's the next hurdle.
Can patients continue with these potentially life-saving cancer therapies, or do these side effects often force them to stop?
Unfortunately, yeah, these IRAEs can be severe enough to stop treatment. The data suggests about 1 in 5 patients, so
20%.
will have to permanently discontinue the immune checkpoint inhibitor because of these immune-related side effects.
1 in 5 stops completely? That's significant.
It really is. It highlights that incredibly difficult decision. You have a treatment that might be working against the cancer, but the side effects are just too severe or dangerous to continue.
A very tough spot to be in.
Extremely tough.
Okay, so given these potential side effects, and the fact these patients already have autoimmune issues, it brings up the whole topic of immunosuppressive drugs.
Right, like steroids or other medications used to manage conditions like rheumatoid arthritis or Crohn's disease.
Exactly. So if a patient is on these drugs already, or if they need to start them because they develop one of these IRAEs, do these immunosuppressants interfere with the ICI?
Do they cancel out the cancer-fighting effect?
Yeah, are you basically stepping on the gas with the ICI and the brake with the immunosuppressant at the same time?
That's the million-dollar question, and it's really nuanced. Again, we don't have perfect perspective data, but the retrospective studies give us some important clues.
Okay.
And the key factor seems to be timing, when the immunosuppression is started.
Timing. How so?
Well, what's really interesting and actually quite reassuring is that immunosuppressive therapy, including steroids, if it's started after an immune-related adverse event pops up.
So to treat the side effect once it occurs.
Exactly. If it's started then, it generally does not seem to reduce the effectiveness of the ICI against the cancer.
Oh, that's good news.
It is. It means doctors have a tool to manage the side effects without necessarily sacrificing the anti-tumor benefit. They can treat the IRAE that emerges.
Okay, so if a problem arises during the ICI treatment, you bring in the immunosuppressants, and the ICI can hopefully keep working on the cancer. That makes sense.
Broadly speaking, yes, that seems to be the case based on current data.
But what about the other scenario? What if a patient is already taking immunosuppressants before they even start the ICI?
Right, maybe for their long-standing autoimmune condition.
Yeah, they've been on, say, steroids or something else for years. Does that pre-existing immunosuppression also allow the ICI to work effectively? Or is that different? This feels like where it could get tricky.
And you're right, that's exactly where the distinction seems critical. Studies suggest that patients who are already on immunosuppression, including steroids, right when they initiate the ICI therapy.
At the very beginning.
Yes, at the time of ICI initiation, those patients may unfortunately have worse tumor outcomes.
Worse outcomes, meaning the ICI doesn't work as well.
Potentially, yes. Less effective tumor response. And adding another layer of complexity, they might also experience a flare of their pre-existing autoimmune disease in this scenario.
Wow. Okay, so starting immunosuppression after an IRAE seems okay for efficacy, but being on it before starting ICI might blunt the effect and still risk flares.
That seems to be the pattern emerging from the data. This difference when the immunosuppression starts relative to the ICI looks really important for clinicians making those treatment plans.
It really underscores the case-by-case nature you mentioned earlier.
Absolutely. It's not just if you use immunosuppressants, but crucially, when.
Okay, that's a huge point about efficacy. But let's flip back to the side effects themselves, the IRAEs. What about the development of those?
You mean, does being on immunosuppressants beforehand help prevent the IREs from happening in the first place?
Yeah, exactly. If you're already suppressing the immune system somewhat, does that offer some protection against these new immune-related side effects from the ICI? Kind of feels like it should, maybe?
That's another really vital question, and the answer here is also a bit complex, maybe even slightly counterintuitive based on what we just discussed about efficacy.
Okay. How so?
Well, first off, whether the patient's underlying autoimmune disease was considered active or inactive when they started the ICI doesn't seem to make a huge difference in the overall rate of adverse events.
So just having quiet disease doesn't guarantee fewer side effects.
Apparently not regarding the overall incidence. However, and here's the nuance, there might be fewer overall adverse events in those patients who are already on therapy for their autoimmune disease when they start the ICI.
Wait, so being on prior immunosuppression might lead to worse cancer outcomes, but potentially fewer side effects?
That's what some data suggests. It's a bit of a paradox, isn't it? It hints at a possible protective effect against developing IRAEs if you're already on treatment, even though that same prior treatment might interfere with the ICI's anti-tumor activity.
Gosh, so you might trade better safety for potentially reduced efficacy.
It seems like that could be the trade-off in some situations. It's incredibly complex, and we definitely need more research to fully understand this interaction.
No kidding. It really highlights the balancing act. Okay, so let's try to sort of pull this all together for you, our listener, and for patients navigating this really tough path.
Yeah. What are the key takeaways?
We've seen that these immune checkpoint inhibitors, ICIs, can actually be effective for patients who already have autoimmune diseases. That offers real hope, which is fantastic news.
Definitely a positive message on the efficacy front for many.
But, and it's a big but, we've also unpacked the significant risks. These immune-related adverse events, IRAEs, they're common, affecting maybe 2 out of 3 patients.
A very real risk that needs careful monitoring.
And we talked about the critical role of immunosuppressive drugs, where the timing, whether you start them before the ICI or after a side effect appears, seems to make a huge difference.
A huge difference for potentially managing side effects, but also possibly impacting how well the cancer treatment itself works.
It really is that double-edged sword, requiring just immense care and attention.
Absolutely. And if you connect this to the bigger picture, it just screams out why managing these patients is so incredibly challenging.
Yeah.
It absolutely has to be a highly individualized case-by-case approach. There's no single recipe here.
Right. It's not a one-size-fits-all situation at all.
Not even close.
Yeah.
It really emphasizes why you need that close collaboration, that team approach, the patient, the oncologist, the rheumatologist, maybe other specialists too.
Everyone talking together.
Yes.
Yeah.
Every decision has to be carefully weighed, looking at the patient's specific autoimmune condition, how severe it is, what type of cancer they have, what their treatment goals are.
It sounds less like following a guideline and more like, I don't know, strategic planning for each individual.
That's a good way to put it. It's complex decision-making, constantly reassessing.
This whole deep dive, it just makes it so clear how vital personalized medicine is, especially when you're dealing with therapies this powerful and patient histories this complex.
Couldn't agree more.
And it leaves us, and hopefully you listening, with a really provocative thought to chew on. As we keep refining these ICI treatments, as we gather more specific data, how can future research really help doctors navigate these incredibly intricate choices?
Yeah, how do we get better at predicting who is at highest risk? How do we optimize both safety and efficacy for these patients facing both cancer and autoimmunity?
Finding that sweet spot, that's the frontier, isn't it? Where breakthroughs could just make a world of difference for people in this situation.
Absolutely. A critical area for ongoing research.
Well, this has been incredibly insightful. Thanks for joining us for this deep dive.
This has been another episode of Arthritis and You, A Joint Journey, brought to you by the Rheum team from albertarheumatology.com. Your trusted, evidence-based suite of resources available 24/7. Straight from Alberta, but for folks around the world. Our hosts today, Arthritis and Sarah Upis, technical producer, John Ifan, and our executive producer, Stephen Cates. While we work hard to maintain the accuracy of our information, we accept no legal responsibility for any errors or omissions. Remember, always check with your own physician first. Join us next time for another Deep Dive.